everybody, and a very warm welcome to the NIHR School for Public Health Research, celebrating 10 years of working together for better public health. I'm delighted to welcome everybody here over the next 2 days, and I hope you'll agree we've got a really exciting programme planned for us all. We have, over the 2 days, over 400 people registered for the meeting, so plenty of opportunity to engage, to interact, and to actually meet with each other. So as I start, I'm just going to tell you a little bit about the programme, but first of all, just a little bit of housekeeping. So just to let you know that Beacon House events will be online from the chat function to help you all day. So please get in touch with you if you need any technical support or guidance. They're in the messages in the blue chat, and they're organisers. There are 4 main areas to the meeting platform, and hopefully some of these you may have explored already. So the reception is the foyer where you can view the programme and navigate into other areas. The stage is where all programmes will be speaking, and this is where we are now. So this is like the plenary area and the stage. There's also a section in there called People, and that allows you to take part in some speed networking. That worked really well last year, so let's see if we can have more interaction on that this year. You click onto that and you're matched with a person for 2 minutes to have an opportunity to do to talk with other people in the conference. And then, of course, our expo area, which you'll have seen information about that's been sent to you in advance. But there's a lot of information on that across the last 10 years of SPHR research, with presentations from our trainees and from public members and from all our projects. You can visit those at any point. The videos are in there. And while you're in, you can use the chat function to leave questions for the presenter. And then during the breaks, when you have opportunity to go into the expo areas, the speakers will be in those booths, in the booths for those, and you can actually interact with each other and talk to the speakers. Do take some opportunity, particularly for some of our PhD students, research fellows that have taken time to make those videos, as well as some of our research programs and themes. So the other thing you'll find in the delegate list is in the expo area is a delegate list. So if you're interested in who else is taking part in the conference, then it's in there. And there is also a brochure which has links to all of the presentations if you wanted to look at those, as well as the biogs for the speakers throughout the next 2 days. And that was in your link that was sent yesterday, welcoming you to the meeting. But Susan is also going to put the link to the brochure in the chat as we're talking this morning. So, that's Dr. Susan Bowett, who's school manager and is lurking in the background along with the people from Beacon House. So that will appear in the chat at some point soon. Okay, so as we take time to celebrate the 10 years of NIHR School of Public Health Research, we're going to showcase some of the work since 2012, when the school was first established. So we're going to take time to look back, and then also to look at the current phase of work, and then at the end of tomorrow to look forward to the next 5 years and our new research programs which we've been planning. So in day 1, on the programme, and you have a copy of this, there's going to be an opportunity now to reflect back on the early days. I'm going to shortly introduce Professor Jon Nicholl, who was the director of the school from 2012 to 2017. John's going to be followed by Jenny Pope, who was deputy director in the first 5 years and also led the innovative programme for FES, our Public Health Practice Evaluation Scheme. And the session there will showcase a couple of the projects from the school programme in the first 5 years, plus one of the fairs. There's much more in the expo, so please do go and have a look at that. After a short break, we're going to then focus on the current 5 years of funding, and we'll be looking at our research programmes and our cross-cutting themes, which are now drawing to a conclusion and will all be complete by September of this year. So lots of findings to share in those sessions. In the remain of the of day one, and then into day two we'll be showcasing the work of SPHR 2. But at the end of today we'll be welcoming Professor Lucy Chappell, who's the Chief Scientific Advisor and also Head of NIHR. Into day two tomorrow, the first part of the day will focus on our academic capacity building function, and that will be hosted by Professor Rona Campbell, who's been the academic capacity development lead over the last 5 years and will continue in that role, but also in this quinquennium has been our Deputy Director. So Rona will be joined by Professor Walter Dillow, who's the Dean of the NIHR Academy. And then during the morning leading up to the break, we'll be hearing from some of our research fellows, pre-doctoral, doctoral and postdoctoral. So we're looking forward to that. There's also going to be a launch of the new NIHR Public Health Incubator website. Straight after the break, we're going to focus on our public involvement and engagement, and we'll have presentations again from Jenny will be speaking, who's led our public involvement and engagement over the last 5 years, as will Professor G.J. Melendez-Torres, who will talk about our future plans. We'll also have some presentations from our public members, and we've got many of them joining us today and tomorrow. So a particular welcome to all of the public members and members of our PAN, our Public Advisory Network, or Partners Advisory Network. We're then going to take an opportunity to look forward into the next 5 years and tell you about some of the 4 programs, a little on the 4 programs that we'll be taking forward. At the beginning of that, at the end, we'll be welcoming Dr. Janelle de Grunchi, who is Deputy Chief Medical Officer and also co-lead of the Office of Health Improvements and Disparities. And in the rest of the afternoon, we'll hear from the 4 programs with a final presentation from Professor Sir Chris Whitty, who probably needs no introduction, but is CMO for England. So we're very much looking forward to hearing from all of our speakers, Lucy Chappell, Janelle de Grunchi and Chris Whitty. Okay, so that gives you a flavour of the day. We're going to look back, we're going to focus on the current, and then also look forward to the future as we go into our next 5 years. Lots of opportunity to see what we've been doing and showcase that, but much more in the expo, and I urge you to use that and also the networking function. So that's that. I think to summarise, do explore the platform, use the conversation. There's a chat function to interact with speakers. We've got Twitter. If you're asking questions during the plenary session, please could you prefix that with a Q so that we know that they are questions, and chairs will be fielding those questions as they appear in the chat. So please just put a Q at the beginning of those of your questions when you put them in the chat. I've mentioned the networking and the booths to visit during breaks and in other sections. And then, of course, we really welcome your feedback. So we'll be asking for some feedback after the meeting to think about what we do next time for our ASM, and whether we can, what kind of platform we continue with, but also content, and the mix of content in terms of discussion, plenaries, and obviously presentations. Okay, so I think now it is my real pleasure to welcome Professor Jon Nicholl. Jon Nicholl was our chair, the director of the school in the first 5 years, and handed over the school in an excellent fit state for me to be able to pick up and move forward with. So and also was incredibly supportive as I took over that role, and I'm very grateful for that. So Jon, I think you're just going to speak without sight for the next little while, so you're very welcome. Jon, please.
Okay, thanks very much, Ashley, and thanks very much for giving me the opportunity to reflect for a few minutes on the origins of the school. But before I start with that, I'd just like to congratulate everybody on the tremendous successes that the the school's had over the last 10 years, and also on the renewal of the school for another 5 years through to 2027. I mean, I think the renewal is a testament to how well everybody has managed to work collaboratively together to actually make the school work. Now, as I say, Ashley's asked me to reflect on the origins of the school, and this has been quite an interesting process for me because I hadn't really perhaps engaged with thinking about this too much, and one or two thoughts have occurred to me which hadn't previously me. One is that I think that the origins of the school actually lie in two, I guess, seismic changes in the health research landscape that happened. I mean, one is completely obvious, which is the launch of NIHR itself. Now that happened in 2006, really quite a long time ago, and it's quite difficult to remember how tricky the research funding environment for things like public health research was prior to the launch of NIHR. I mean, most of the public health research funding that was being spent was actually tied up in some very long-term epidemiological studies funded by the MRC, and really practical research was considered to be inferior. Health service research, some of you may remember, was actually characterized as counting bedpans. There was really no room for primary care research, and I think social care research was effectively non-existent. So when NIHR was launched, and it was launched with, even then, with quite a decent amount of funding, it suddenly made all sorts of practical public health research available. The second foundation, however, for the school is perhaps rather more contentious, and I think what it is the perceived contrast between the tremendous success of research in clinical medicine and the perceived lackluster progress in research in public health and primary care. I mean, clinical medicine, pretty much since the end of the Second World War, has the research has made a tremendous difference, and everybody understands this. And whether it was the development of trials methods or Dave Sackett's evidence-based medicine policies, or I don't know, the development of genetics, competition, funding. I mean, that could all be argued about, but the point is that there was a perceived, and I think quite correctly perceived, huge stark difference between the success of clinical medicine research and progress with research into what works in public health and certain other areas of health research. So with those two foundations, the opportunity provided by the NIHR and the drive to try and bring public health research up to the sort of level clinical research was enjoying, we had the environment for the launch of the school. And the then Chief Medical Officer, Sally Davis, who of course was the founder and the initial director of NIHR, rather unkindly known as the nation's nanny by some of the press. She had already launched the School for Primary Care and Social Care. And so when the coalition government came in 2010, and in November 2010 launched the public health white paper, Healthy Lives, Healthy People, it was an opportunity, I think, to initiate the School for Public Health Research. And that white paper actually said that the best evidence will be used, and in order to do this, an NIHR School for Public Health Research would be launched. Now, I have a paper originating from the Department of Health, which identifies 4 particular specific drivers for the development of the School of Public Health. And one of those is the one that I've alluded to, which is a perceived contrast between the success of clinical research and other research. A second was that the School of Primary Care, which was initiated 3 years earlier, had just begun to show that it was possible for such a school to begin to deliver potentially useful research programs. But the other 2 drivers that were identified by DH were, one, the widening social inequalities, I guess probably mainly identified by Michael Marmot and other researchers like Jenny, of course, but the widening inequalities between social and ethnic groups particularly, but also the relative lack of progress in public health itself compared to the obvious fantastic gains and successes of the early part of the 20th century. I mean, obviously mainly brought about by things like antibiotics and so on, but nevertheless, public health improved dramatically between the end of the 19th century and the middle of the 20th century. And it was seen that these improvements in public health had slowed down. So these drivers led to a call for a school for public health, and that came out in 2011, and there was a process of selection of members for the school, which I wasn't involved in. And then in the autumn of 2011, I got a call from Sally, not the first I'd had, and certainly not the last I got, out of the blue, with what she described as a small request to launch the school. Now, she was a little bit vague about what the school would be, how it was to be sort of organised and constructed, with a couple of exceptions. I mean, one was we weren't allowed to call it sofa with an O, or settee, or any other even slightly humorous name. That was banned. The other thing was that unlike the schools of primary care and social care, who hold most of their funding, or held most of them funding centrally and then distributed it to members in one way or other, the School for Public Health was to distribute all its funds to the members and only hold a small sum centrally. This led to some problems, which I'll describe in a moment. One thing, however, was emphasized to me about the school was that there was a real desire to have a step up, not just in the quantity of public health research, but in the quality of public health research. And it was believed that bringing together the best researchers in public health from across the country to collaborate in research was the way to improve the quality. We were repeatedly urged to ensure that the school was more than the sum of its parts, that we were to somehow create a school which was more than just the totality of the individual research successes that the members could contribute. So at the core central mission of the school, I think really was to address some grand challenges, some big challenges in public health, which needed big, high quality research, and to try and crack them. And I think that was the original idea, and I actually think it remains the central idea for us to address. Now, the initial phases of the school, I think the members, I mean, I think Jenny, following to speak to me, to this conference after me, you might remember the dreadful mess of financial arrangements. I mean, this arrangement of distributing all the money to the members and not holding it centrally, unlike the other schools, meant that the financial complexities were absolutely gargantuan, and we spent, I know, just so much time on it and so much administrative energy trying to sort out those arrangements. Fortunately, I had a fantastic management team with Jenny Poppe as the deputy director, Mark Pettigrew, and our school manager, Catherine Porter, and they were a fantastic help. And I'm grateful to have this opportunity to thank them for all the help that they provided. The members also showed considerable willingness to help, and they put a lot of goodwill into trying to make these terribly complex arrangements, which were entirely my fault, but foisted on us by the financial arrangement, make them work. And then, having sorted out these arrangements, the members went off to begin and initiate some of the fantastic research, which you're going to hear about throughout the conference, and the impacts that research has had. So I'd like to finish just by reflecting on the school and some of these things. I mean, the first thing is, as I've said, is that I do still believe that the core mission of the school is to identify some grand challenges which need big, long-term, multi-environment, expensive research to crack. I mean, it has other responsibilities, of course, engagement and training, and these are important. But the core mission of the school is about those challenges. I think that's the case. The second thing follows from that, which is, I think that the financial model, particularly the stop-start every 5 years, doesn't work for public health research. I mean, that model was developed for basic medical research, which it covers perfectly well. In fact, most clinical medicine research fits into that. Health service research, which I did a lot of, and delivery research tends to fit with that sort of timetable. But big public health challenges need a different timetable, a different funding model. And I really think that it's up to the school and Ashley and so on to keep nagging away at NIHR and the Department of Health about that funding model. The third thing is that this question which I talk to Jenny and colleagues about a lot, which is, what is a school? I mean, what was the school? And I think this is something which I was very concerned with, which is, it seems to me that the point of a school is to create a community of researchers, that by collaborating with, all right, just a limited number. It's not all public health researchers, it's a limited number. But by collaborating with these same researchers repeatedly on a day-to-day basis, we create a community of researchers. And that community of researchers, call it a school, that's a perfectly good term, that community of researchers does enable us to deliver research in ways which I think just what you might call convenient collaborating doesn't necessarily do. So I'd like to just finish again by congratulating everybody on the fantastic successes of the school over the last 10 years, and wish you all the very best for the next 5 years. And I think we should all now stand up and sing the school song. Is that right, Ashley?
Okay, so thank you so much, John. You've presented lots of challenges, great reflections. I'm just thinking that the school began with the white paper and healthier lives, and here we are, we're starting the third quinquennium, just waiting for the white paper on health disparities.
Yes.
And so we're in a similar, that situation, and also much has changed through PHE, OHID, and of course PHE didn't exist at the beginning of the school and came into existence, and now we have OHID and UXA and so forth. So things have changed, but the school is here, and I think that community and collaboration is something that I'm hoping over the next couple of days everybody will see the evidence of what that sum of the parts and what is a school, and that collaboration, and also that step up in terms of quantity, but more importantly quality of the public health research that we have been able to do over the last 10 years and will continue in the next 5. So thank you so much, John. It's been a real pleasure to see you, and I'm sure everybody else has enjoyed those reflections, and I hope that you'll stay and watch some of the rest of the programme. We're going to move on now, and I'm going to introduce Jenny Pope, and also to have some examples of the impact and innovation from the first 5 years that John's been referring to. We'll have a short presentation from Professor Jon Nicholl about the public health practice evaluation scheme, and also some videos for some of that work. So just now to introduce that next session, please. Which I think, and it starts with a video, and there will be an opportunity for some Q&A. So please put your questions in the chat if you have them. Thank you very much.
Hello, I'm Judy Kidger. I'm a senior lecturer at the University of Bristol, and I'm going to discuss the impact of a study that the School for Public Health Research funded during its first 5 years. Following evidence we'd gathered that staff mental health in schools was neglected, we formed a team across Bristol, Exeter and King's College London universities and received SPHR funding to develop and test out a mental health intervention and its evaluation in secondary schools. The intervention had 2 components: training staff in mental health first aid, who then set up a peer support service as a first port of call to support their colleagues, and training staff in supporting student mental health. Mental health first aid is evidence-based training developed in Australia that equips people to spot the signs of mental health difficulties in others and to have the confidence to proactively provide support. Our study had 2 phases. The first was a 1-year feasibility study in 2 schools where we tried out the training and outcome measures and made changes where needed. The second phase was a pilot randomised controlled trial. We recruited 6 schools and randomly allocated them to receive the training and peer support service, or to be a comparison with no input beyond usual practice. These were our research questions, which covered the feasibility of the intervention itself and the mechanisms by which it might work. We successfully carried out the study, and despite its small scale, it has led to some important impacts. Our findings fed into a new product developed by Mental Health First Aid England, specifically a 1-day course that was more accessible for teachers and had more of a focus on practical help. We also raised the profile of teacher mental health. 2 papers that we produced from this study highlighted, number 1, that teachers do have poorer wellbeing and higher depressive symptoms than general populations, as shown in the graph. And secondly, that there's an association between poor teacher mental health and poor student mental health. And although these things sound intuitive, good evidence was lacking before our study. Our findings about the importance of teacher mental health were also included in a report by Public Health England. A key impact was that our evidence regarding the feasibility and acceptability of the intervention and its evaluation led us to a successful bid to the National Institute for Health Research's Public Health Research Programme to conduct a full cluster randomised controlled trial in 2015. This full study has now concluded with further impacts to report. Unfortunately, we did not find the intervention, when fully evaluated, led to improved mental health outcomes in staff or students at population level. However, we did find evidence in our process evaluation of increased knowledge and confidence among teachers in the intervention schools to support their own mental health, that of their colleagues, and that of their students. As study principal investigator, I was invited onto the expert reference group for a Department for Education rollout of the mental health first aid for schools and colleges, which involved one teacher per every secondary school receiving the training. And we further raised the profile of teacher mental health through papers and presentations to policymakers and school staff. And in particular, we used our process findings to highlight the need to address workplace causes of poor mental health and to create structural changes. These are the links to the 4 papers reporting outcomes from the main study. And I'm really happy to give the last word now to a teaching professional who was on our study team and who reflects here on why the study was valuable to those involved.
And I certainly noticed that my practice, my personal practice, was enhanced from my involvement in the scheme, and also my understanding of supporting others with their mental health, students and colleagues, and also advising my head and SLT on what was available, what we could possibly do to enhance our whole school provision around mental health. So certainly there was a profile raising consequence of having been involved in the study for me, for my school, and I know from colleagues in other schools that they felt, having been part of the pilot and also all part of the research project, that this was also true of their schools. So without question, a positive outcome. I also feel that where staff were involved in the project, internal school training, CPD, continuing professional development occurred, so that staff could tell other staff members about the training that they had received. Again, not just profile raising, but also enhancing practice across the board for a number of different staff from different parts of the school and different roles within school. So the benefit of the involvement in the scheme, and also in the nature of the provision that the WISE project implemented, whether you were part of the pilot or the research project, was really positive.
Thanks very much for listening.
In this research, we wanted to find out if we could work in partnership with industry to get fish and chip shops to offer small portion meals to all customers at all times. Public health teams have found it difficult to engage with takeaway owners, but we discovered that wholesale suppliers and fish and chip shops are trusted by owners and offer a way to influence portion size. We worked with Henry Colbeck, who are a major supplier to fish and chip shops in the north of England and throughout Scotland. Together, we developed a team spirit event to which a select number of fish and chip shop owners were invited. At this event, Henry Colbeck staff detailed to owners the financial benefits of offering small meals. Colbeck were able to offer a range of packaging for fish and chip shop portions, as well as promotional posters for owners to display in their shop to inform their customers. Working with 12 local participating businesses, we collected a range of data, including business setting, sales, and customer, owner, and supplier experience of the scheme. We found that owners and customers welcome the scheme, demonstrating that it is feasible to work collaboratively with industry in this sector to promote healthier takeaway food. However, there remain wide variation between individual fish and chip shops, and more work is needed to define the ideal size for healthier small portions.
The Foodscape project was a fantastic experience. It brought together many minds within the industry to talk about and discuss the real issue of portion control, to the point where it actually spurred Henry Colbeck on to think creatively about how to help combat this from a commercial point of view.
So when we first got involved in the Foodscape, what was interesting from our point of view at Longsands was we were looking at offering a smaller portion. So what we did, we introduced a smaller size box. The portion still looked a big size, but because it was in the correct size packaging, people were opening the box and actually seeing value for money. With introducing our packaging and then getting involved with Foodscape, the two tied in. And what helped me promote the smaller portion was the feedback that we got from the customers through Foodscape.
In 2014, the LILAC team was funded to undertake a study investigating the impact of reducing the cost of using local authority leisure facilities. The research was funded by the FES scheme and was led by Ben Barr and myself, Emma Halliday, at Liverpool and Lancaster universities. The context for the research is that there were continue to be inequalities in participation in physical activity in the region, and local authority professionals had approached us because they were interested in understanding whether their investment in free or concessionary leisure was having any impact on participation for local populations. The research treated the leisure pricing policies of these local authorities as natural policy experiments to evaluate the impact on health inequalities, and a total of 7 local authorities took part in the research. The methods include qualitative methods with members of the public and professionals, as well as quasi-experimental techniques involving the extraction and analysis of leisure systems data, as well as existing survey data. There was a strong focus on co-production and engagement in the research, and in particular, we'd really like to thank our local authority partners and also members of the public who were involved as advisors to the research, because their contribution was extremely important to the success of the research. Practically, there was involvement of local authority teams in helping us to navigate and interpret the leisure systems data, which was available on participation in facilities across the region. We also set up a research advisory network to help with the transferability of the research out with the immediate region. So this involved, for example, representation from the Association for Public Service Excellence and Public Health England at the time. And there was a particular focus on public involvement of local residents who were living in the local authorities where the research was being carried out. So turning now to look at some of the key headline findings, certainly from the public interviews and focus groups we conducted, we found that affordability was a major factor affecting how people used or did not use leisure facilities. This particularly was a factor for people receiving welfare payments in low-wage households, or also people who were retired. And it led people to navigate leisure facilities at different ways. For example, where free leisure was provided through free universal leisure schemes, this led people to only attend when charges were free, or in other cases to only attend when charges were provided at off-peak times or were offered in other concessionary ways. We also found that people talked about pay-as-you-go options being the most manageable way of using leisure facilities because it involved not having to commit, but of course it was the most expensive. And as this quote highlights, this individual talks about the cost of milk and bread, but also wanting to keep active and seeing the amenities in their local areas, but not being able to afford to go in. And then turning to look at the findings for health inequalities at the local population level, certainly we found through investigation of 2 schemes, a universal free offer in Blackburn with Darwin and free holiday swims for children in Blackpool, that there were significant impacts on participation, and particularly these were seen amongst more disadvantaged groups. And we also saw that beyond those schemes, that concessions for those aged 60 or older also had some impact on, at least temporarily, delaying the decline in participation. In terms of impacts, we've produced outputs and resources and contributed to NIHR resources such as a Moving Matters review. Ben's work on leisure systems data has helped to build capacity locally, and also the research has had a direct impact on local decision making for one local leisure scheme, and as well has contributed to making the case for further investment, which is actually now the focus of a further evaluation led by Ben. So to conclude, and this slide provides our contact details and also provides a link to a case study on the SPHR website, where you can find all the outputs from the resource and links to further information. Thank you.
I'm Jenny Popey, a member of the School of Public Health Research through the LILAC collaboration between Liverpool and Lancaster universities. And I'm going to be talking to you about the Public Health Practice Evaluation Scheme. The FES, as we affectionately refer to it, was established in 2012 when the school first started, and it aimed to contribute to the school's overall objective of producing high quality research evidence for public health practice that would improve health and reduce health inequalities. FES was innovative in that it sought to develop new, more inclusive, equitable research relationships between SPHR academics, the researchers, policymakers, and practitioners in local authorities and civil society organisations, and always included public partners. So the aim was to work in partnership with these colleagues to evaluate local initiatives that have potential to improve population health and reduce inequalities, that could be transferred to other areas if found to be effective, and that have not been robustly evaluated before. Since the scheme began in 2013, we've funded 26 local initiatives. In 2017-18, we conducted an internal evaluation of FES to find out what had worked well and how it could be improved. We spoke to SPHR researchers involved in FES projects and also to public health policymakers and practitioners in different sectors who had been involved in FES evaluations or who had submitted applications that were not funded. The highlights, the main findings from the evaluation was that FES provides much needed resources for local evaluations of initiatives, that it produces evidence on what works, but also crucially on why things don't work so that they can either be adapted, improved, or stopped. It strengthens relationship between practice and academia, but there can be tensions. For example, practitioners have more pressure to show that things work. Academics are under pressure to publish, but these pressures were always effectively negotiated within the FES projects. The types of improvements that were highlighted included the need for more support in the development of applications to the FES scheme. These applications come from practitioners, policymakers. More process evaluations into why things worked or didn't work alongside impact evaluations. More flexibility to respond to delays implementing interventions. So for example, delays in funding or staff being in post. Funding for the dissemination of findings to ensure that the initiatives can be taken up in other areas when they're found to be effective. And more feedback on why applications were not successful. There were also a concern to try and reduce geographical inequalities in opportunities to apply to FES. The unevenness of these opportunities is an inevitable consequence of the fact that the members of SPHR are not geographically spread across the whole of England. To give you some idea of that, here is a picture of the applications that were received and the projects that were funded in the 2019 call, the latest FES call. Please ignore the detail here. Just look at the pattern. So overall, we had 91 expressions of interest to this call. 44 outline applications were submitted, and 10 local initiatives evaluations of local initiatives were funded. And as you can see, although the spread across the country has improved over time, it's still very much concentrated around SPHR members. You can see here, Fuse in the northeast, Sheffield, we've got Cambridge, and of course there's a concentration in London with the London School of Hygiene and University College London, concentration around Bristol, and a concentration around Lilac in the northwest. In this quinquennium, we have 2 new members, Exeter down in the southwest, so that will increase opportunities here, and in the Midlands, a collaboration between Birmingham, Warwick, and Keele. So let me give you some examples of the type of projects the type of local initiatives that are funded, are evaluated through the FES scheme. The one with the red circle is the one that Emma Halliday told you about just a little earlier, with local authorities reducing the cost of leisure facilities. What was the impact of that on health and social inequalities? As you can see here, the FES projects that are evaluated are very diverse. So we've got focus on oral health intervention, interventions preventing domestic abuse, interventions to promote smoke-free homes, an intervention to license private landlords as a way of improving the quality of privately rented accommodation. So they're very diverse projects, all local projects, but of course, some of them are quite large. So the London-wide HIV prevention program that was evaluated was across the London area. So in summary, FES is successful. It generates research and practice impacts. It contributes to capacity building in research in both practice and in academia. It's valued by practitioners. Since it began, we've had 124 outline applications submitted, and there are ongoing inquiries about future funding calls. But as I say, there will continue to be geographical unevenness in the opportunities. And in that context, NIHR has now launched FIRST, which is the Public Health Intervention Responsive Studies teams, which have England-wide reach, which local authorities can apply to for evaluation of their initiatives. So in that context, SPHR 3 will continue with FES, but we will probably strengthen our focus on the civil society or CVSFE sector. So thank you for listening. We're very proud of FES, and we're really pleased that it has influenced the new NIHR FIRST initiative. So for more information on FES projects, please visit the Expo area. Thank you.
Thank you, Jenny, and all the other speakers. I hope that gives you a flavour, but please do go to the Expo area to have a look. We are running a few minutes late, so what I'm not going to hold us up any further. There has been some questions in the chat that have been answered in the chat, so please continue to do that, and we will have opportunity for discussion later. So please enjoy a short break now and come back at 2 o'clock. Where we'll restart the programme, and the Expo area is remaining open and the networking throughout all of the breaks. So see you very soon.